this one is not as brain stimulating as the previous one, and there is nothing artificial about it for the time being. It is all real. What is the goal of interventions when we are doing bronchoscopy? Goals can be diagnostic, where we can do a bronchoalveolar lavage for infections, hemosiderosis, alveolar proteinosis, tuberculosis, endobronchial biopsies. Transbronchial lymph node biopsy, IBUS, transbronchial lung biopsy, transbronchial lung cryobiopsy. These can be diagnostic interventions. Therapeutic interventions can be a foreign body removal, which is very commonly talked about. Do we have a pointer, please? Total lung lavage for protein alveolar, pulmonary alveolar. Anyway, so we can do balloon dilatation of subglottic stenosis of this type. We can do tracheal stenosis, or web can be dilated. Cryoablation of these can be done to create more space there. We can use laser. We can use fistula closure with glue. We can use stents for various stenotic areas. Single lung intubation can be done, and bronchoscopic intubation can be done. These are the interventions that we can do for therapeutic purposes or to treat the patient. Let's share some experiences with you. This is a child who's just 6.5 years old, had MRSA pneumonia, ventilated for 1 week, was discharged after 4 weeks of being in the hospital. She had a bad phase in another hospital. She presented to us with stridor, and that stridor was unnoticed by the parents. They had come for just a routine checkup before the child was to go to US the next day. And she was having a bad stridor, and this was the only opening that was available for her breathing. So, if I was not believing in God till then, I started believing. If that little opening, she was roaming around happily in the corridors and was all set to fly to US the next day. What did we do? We evaluated and did what was required. So you can see that that is the only opening there. That little one, which opens during inspiration a little bit, during expiration it collapses even further. Then we did, this is called grade 3 subglottic stenosis according to that classification. We balloon dilated that area. You will see the balloon coming in. This is the balloon dilatation being done. After balloon dilatation, things became somewhat better, and the grade 3 was converted to grade 2. Here we are now going to use the cryoprobe to create more space there. The cryoprobe is this blue thing that you would see. It goes, and when I press the button of the paddle, this becomes white. You see the ice forming there? So this is what the cryoprobe does, and we were able to create from this, we could reach this stage in our first setting. And in the second one, we could dilate even further and create an almost normal airway. So this is what can be achieved. This is a list of the cases that we have been doing. Here is another example. That is the only little space that is seen. Probably there is an opening there, probably not. Of course, the child has a tracheostomy through which the child is breathing. And if we see these three, there is so much of tissue that we can't really do anything about it unless we do some surgery. But in this posterior one, I can see that there is very little tissue. If I can penetrate through this, I would have created a space there. So this is what we encourage us to do something. And we are doing this bronchoscopy, and you would see that 2 bronchoscopes are being used, one and the second. One bronchoscope in my hand, one in my colleague's hand. We passed one bronchoscope through the tracheostomy tube into the airway. The second one is through the nose into the subglottic, into the glottic area. That little space that you saw, we entered that, and we could see that we have inserted an instrument inside which has reached the airway. So we are sure that we can dilate it. So this is what we do next. In our first sitting, that is where we start from, and this is where we come in our first sitting, using cryo, and then the second sitting, the third sitting, and in the fourth sitting, we are totally normal airway, almost normal airway. So this is what can be achieved in some cases. That is the end result. You would see where the stenosis was. There is something there. It is not perfectly normal, but you can see a huge normal space there for the child to breathe. The next case is a tracheal obstruction case. This is a 10 months old who had tracheal hemangioma with severe central airway obstruction, came to us in the COVID days. Child presented with history of noisy breathing since 1 week. There was associated cough, fast breathing, chest retractions. CT thorax has been done outside, which showed a polypoidal mass here in the trachea, that is esophagus. You can see a mass there. That was a few days back. Another CT scan was done for getting full reconstruction. You can see there is a stenosis there. There is some polypoidal mass here in the trachea. Again, the same views. And this is the bronchoscopic view of what is going on. Almost a total blockage of the trachea by this polypoidal mass. So we are using the video bronchoscope here. You can see the picture is better, but we know that we can't pass through it. So what we do is we take a smaller scope, and this one we try to pass beyond this. So this is the abnormal area, and we have gone beyond this. You can see we have reached the carina. So we know that we can go ahead. Of course, the child is breathing, so there must be enough space there. So IV steroids and propranolol both were used in this together, because looking at the dangerous situation there, observed for a few days in the PICU, and then in the ward, respiratory distress became slightly better. He was feeding well, and in spite of retractions, the child was happy. We sent him home. But he was readmitted after a few days with viral-triggered respiratory failure. HHF Benzi was required, scopy was repeated, and same findings were there. During inspiration, the blockage of the tracheal lumen was 90%. During expiration, it was somewhat less. Here is the bronchoscopic view at this point of time. So you can see that there is some space, but the polypoidal mass hangs around and sometimes gets sucked in, sometimes sucked out. So the child has a distress. So pediatric surgery consultation was taken. ENT surgeons were involved. Differential diagnosis was whether it is tracheal papillomatosis or hemangioma. With our experience of so many years, I've seen so many hemangiomas, I was certain that this is hemangioma. And to corroborate, there was a small hemangioma on the chest of skin of this child. A pre-surgical biopsy was taken by surgeons, and this is where the surgical biopsy is being taken. This was reported as hemangioma. They were not too sure. They wanted to be 100% sure before going ahead with further. Laser cauterization of the tracheal mass was done, but it could not be removed completely because it was very close to the tracheal wall, or in fact a part of the tracheal wall. Here you would see some smoke coming out when the heat energy is being used to ablate this area. This is being done by our surgeons. You can see that smoke coming. And after some time, you would see a lot of space has been created, more was created. But then this is what the surgeons did, and after that, child was sent to us in the ICU with on-mechanical ventilation. There was, of course, thick secretion. There were lots of difficulties in ventilating. This was the X-ray at that time with the chest tube in. Now, our part was, when can we extubate this child? When can we even try to extubate this child? So, of course, through the endotracheal tube, we are doing a bronchoscopy to evaluate when can we do. You can see that burnt area there. You will see something hanging around which has not been able to, they have not been able to remove completely, but you can also see the carina there. That means a lot has actually been done. So, after looking at this, we know that if this doesn't break through in another day or two, then chances are healing would occur, and we can try and extubate. So this child was extubated after a few days, no endotracheal tube, and everything looked reasonably better. And on follow-up, you would see that it is not a perfect trachea, but you can see at the same scope which could not be passed beyond, now only this little hanging tissue is there, everything else became normal. So evaluation, and child was happy. Fistulas. What do you do about fistulas? If they're inoperable or a recurrence occurs or it's a post-surgical, post-procedure, post-infectious, tracheobiliary fistula are the examples that we'll take. This is a child who had high-grade fever for 7 days, cough for 7 days, breathing difficulty, retractions, and these were the X-rays of his showing a lot of pneumonia there, necrotizing. Child recovered from this in the sense that fever and everything settled, but the chest tube continued to show a lot of air coming out, so we diagnosed bronchopular fistula in this child. Clinically, we looked at the whole thing from the one tube was not enough, second was required, so bronchopular fistula was diagnosed on this, and we did an evaluation through the bronchoscope to see if we can block this area from the inside. So we instilled some saline with methylene blue in the scope and observed the chest tube. You can see you would see some blue material coming out here. This is the chest tube. You can see this running. Such large amount of air is coming, and there you would see, now we have pushed some more saline onto it, and you see more blue material coming out in the chest. So what we were injecting into the trachea is coming out. So after that, what we did was we instilled glue into this. This is the glue that is used. It is just 1,000 rupees, and this does the job. So after using the glue, we could see the child is comfortable, and you would see the column has stopped moving. You would see the column has stopped moving. Then and there, on the table, we know that we have closed the fistula. So follow-up X-rays, things became better. Another child who came from Iraq, surgery was done in Iraq for esophageal perforation following a battery ingestion. False passages were created, real esophagus could not be identified. You see, this is one esophagus, that is second esophagus, there is a third esophagus. Nobody knows what's going on there. Our surgeons created one esophagus where at least a tube could be passed down, although they could not do much about this. Child could not be extubated, and you could see the endotracheal tube, you see chest tubes, one does not work, the second did not work. We did a bronchoscopy and found that there's a small little suspicious fistula there. We put in a probe there, and the probe went through. The probe you can see this is the bronchoscope, and the probe has gone down into the abdomen. So that is the fistula that is there, and glue was instilled, fistula was closed, pneumothorax resolved, child was discharged. Here is a congenital fistula that the usual tracheoesophageal fistula. It could not be closed by the surgeons very well. Child kept coming to us in the ICU repeatedly with severe retractions, would be intubated and would again be back and so on. So in that one, we instilled some methylene blue here, which was detected, methylene blue put here, it was detected in the esophagus. We know that there is an opening which is still there. Then we knew that opening is there. Now we try to push a small, is the thinnest possible node bronchoscope through this opening. That is the carina, and this is the abnormal opening. When we pushed it in, it went into the esophagus, and you would soon see a NG tube there, nasogastric tube there. Yes, you saw the nasogastric tube, and we are back into the carina. We again inserted it there, and you would see that we have reached, this is a nasogastric tube that you can see the blue thing. And finally, we were in the stomach where the gastrostomy tube could also be seen. We had gone through the bronchus. So the fistula was open. It was reoperated, and that is the gastrostomy inner end. Another case of same type, the fistula, according to the surgeons, it is an international patient. Again, some countries, surgeons are not good. Fistula not really closed. So again, this time we used iodine, provider iodine for looking at the fistula. Another fistula is, this is the fistula there. We all missed it. We had done a CT scan till we did a bronchoscopy. And on bronchoscopy, I think the next one, yeah. What did we find? You can see a fistula there. Take left bronchus, right bronchus, something coming out from there. And you would see a yellowish kind of fluid coming there. I was very, very surprised to see almost yellow fluid, which my colleagues seeing there said, "Sir, it looks like bile." And I was quite surprised. And that is exactly what turned out to be. It had 4 mg% of bilirubin in it. And then we investigated accordingly, and this is what we had missed. It was already seen in the liver also, and when we did a HIDA scan, we could demonstrate it. We did an MRCP scan to demonstrate it. Our surgeons closed it, and we could publish it in one of the international journals. Now, this is a child who's come to us in COVID days. 4 years old, recurrent chest infections, cough, breathlessness every 3 to 4 weeks, response to antibiotics, nebulized medicines do not give immediate result, breath sounds are markedly decreased on left side, and rhonchi on the right side. This is what it is. This one child is trying to give us very little history. They don't want to tell us that anything has happened in the past because they have to claim insurance. Here we see magnified view. You see some surgical clips there. Child has undergone surgery and they're hiding it from us. This was the first, when we came to know, then they told us, yes, this was the first X-ray before surgery. And this was the mass which was removed. This is the mass from the preoperative CT. And in July 23, this is what was done, and sorry, 22, and this is when they came to us with diaphragm there. We did a bronchoscopy, and this is what we removed from inside the left main bronchus. This is a large cast which is more than 3 centimeters. After removal, things would look better, but there was some malacia also. And it was reported as residual teratoma, no rhabdomyosarcosis. So we sent the child back to the oncologists. Similar, another patient where these casts can cause problems. TBNA, if you have such lymph nodes and you want to do a biopsy through it or take an aspiration through it, yes, this is what you can do. Either do an open thoracotomy or a media stenoscopy, but you can also use the bronchoscope to look at inside, and if you are able to see some lesion, you can take biopsies from there. You see a lesion there, you can do a brush biopsy or a proper biopsy from there, and this is the other biopsy being done in the same patient. Now, what of course we can do is do a transbronchial needle aspiration using this. Here, you would see a needle is going to come and pass through the right main bronchus just at the beginning. That is the left main bronchus. We are at the carina. You would see a needle coming. This needle will go through it into the mass that we have seen in the subcarinal region and get a aspirate from there. We are doing it blind. We don't know exactly where it is going, but from the CT scan, we know where it will go. So, better way would be to use an ultrasound. This bronchoscope has an ultrasound here. It is called endobronchial ultrasound. And this is the needle that we can insert. And this is exactly what we did in another patient. Depending on which lymph node you want to penetrate, you would position your bronchoscope accordingly. And the ultrasound waves would pick it up. The needle can be inserted. And here is a video to show you what it happens. This is what that lymph node looks like, almost like a liver. And you see something white coming in, a needle coming in, needle going out, needle coming in, needle going out. And you can see the bronchoscopic view here. This is ultrasound view. You can interchange them. This is what we have done and got the aspirate and found the answer. So we have done so many procedures by now, and most of them are related to tuberculosis or sarcoidosis and such MDR, tuberculosis, persistent LCH disease, mediastinal mass, and such are the other thing that we can do is a pediatric bronchoscopic biopsy. If you have this is a patient who had this kind of pneumonia which was not resolving. It did not look like a pyogenic pneumonia. Pediatric bronchoscopic biopsy was done. Again, this was COVID days, so we had to take all precautions. And this is what came out of the biopsy. We had a Mason body and all these features are typical of cryptogenic organized pneumonia, what used to be called at BOOP. So cryo can be used for biopsy, can be used for cryoablation. I showed you a patient, and we can also use it for foreign body aspirations. A novel bronchoscopic technique it just freezes the tissue there as it is shown, and as I had shown you in a video earlier. This is a list of our cases of things. Foreign body removal, of course, is something that can be done very easily in most of the cases, but of course we have to make a clinical diagnosis if we can, otherwise it can be something which is not easily detected. It may be as easily detected as this, or as this, or as this. But some may be very easy to grip, like this one. There may be those which are very difficult to grip because there is no space around, and it can be single, it can be multiple pieces, it can be, and if you remove it by scope, somebody had done it, and this can also happen. Pneumothorax, pneumomediastinum, air, hair, there, everywhere. So you have to be careful. But most dangerous foreign body is the one which is there at the glottis. So you would see, here we are going through this is the glottic area, vocal cords. As we go in, we are trying to take out one. We have picked up one foreign body there, and there's the second one hanging there. We pick up the second one, and as we are picking up the second one, a third one will pop out from there, and that is what can be the most dangerous thing, because if one gets stuck here, your patient is dead on the table. So this is, again, another patient who was 3 years, 4 months old. This is the kind of...
We have lack of time, sir.
Okay, so I'll finish with this case. This is the child who has this kind of pneumonia everywhere. You can see this is the pneumonia that looks like pneumonia. This is what it is. And clinical or radiological diagnosis is alveolar proteinosis. And we do a lavage. This is what comes out. We do a biopsy, and biopsy reported as suggests alveolar proteinosis. BAL suggests, and biopsy gives you a complete diagnosis of features of alveolar proteinosis. So child is treated accordingly. So this is another patient who had lipid pneumonia, and we had to do repeated lavages. We would put in this. This is what will come out. 76 times this had to be done, and ultimately child survived. Thank you very much. So interventions can be helpful in selected patients. Yes, there are problems, there are dangers, there are equipment requirements, there are skills required, but they can be useful in our hands also. Thank you.
Thank you, sir, for such interesting cases, and we learned a lot. I think we are already short of time, and the time is over, so I think we can take the questions later on. Thank you very much. Thank you.